I start with the name of Allah, the Lord of Mercy, the Giver of Mercy. I am Dr. Muhammad Yusuf Hawan, and I'm a consultant physician. This is my third lecture in the series of 4 lectures on the localization of neurological lesion. In the first lecture, I discussed localization in an unconscious patient and a patient in a coma. In the second part, I discussed localization based on anatomy of the brain or anatomical localization of the neurological lesion. And this third part, we will discuss localization of neurological lesion based on the brain circulation. So the brain circulation. So we'll start with a question. 60 years old man with a history of diabetes, hypertension, and hyperlipidemia has suddenly developed agitation. Examination shows left hemiplegia and hemianesthesia. The patient has right gaze preference. So where is the lesion? Left middle cerebral artery, left anterior cerebral artery, right middle cerebral artery, right anterior cerebral artery, or vertebrobasilar system. So you can pause the video and think over it for a minute and come back to the discussion, please. So this briefly this figure diagram briefly describes about the circulation of blood circulation of the brain. And there are two systems which are supplying blood to the brain. One is called the anterior circulation of the carotid system. The other one is the posterior circulation of the vertebrobasilar system. The aortic arch, from the aortic arch, it gives rise to the common carotid arteries, and from common carotid arteries arise internal and external carotid arteries, and then internal and external carotid arteries divide into the anterior cerebral artery and the posterior cerebral and middle cerebral artery. So the anterior cerebral artery and the middle cerebral artery are the branches of the internal carotid artery which supply the anterior part of the brain. Two vertebral arteries, these combine to make a basilar artery, and this system, the basilar artery divides into posterior cerebral artery and anterior inferior cerebral arteries, and this supplies from the posterior part of the brain. So carotid system supplies the anterior part of the brain and is known as anterior circulation, while the posterior part of the brain is supplied by the vertebrobasilar system, and this is called the posterior circulation. So vertebral arteries, two vertebral arteries joining into the basilar artery and dividing the basilar artery divided into the posterior cerebral artery and superior cerebellar artery, and this system is the posterior cerebral artery, posterior circulation of the brain. Right from the common carotid artery divided in the middle cerebral artery and the anterior cerebral artery, and this anterior cerebral both anterior cerebral arteries are connected with anterior communicating artery, and this forms a circle of Willis, and this is called the anterior circulation. Again, the same figure with more elaborate labeling. Right, though these arteries supply different parts of the brain, and this spot, the yellowish part, this is supplied by the anterior cerebral artery, but the lateral surface, this area is supplied by the middle cerebral artery, and this is the posterior cerebral artery circulation area. So if you look at these things, the part of the middle brain and some part of the frontal lobe and anterior lobe, part of the middle frontal lobe and the temporal lobe was supplied by the anterior cerebral artery. This is wrong. This is anterior cerebral artery, and this is the middle cerebral artery. This bit confusing. This color is anterior cerebral artery, and this color, the greenish, is from the posterior middle cerebral artery. So this is the anterior circulation, and this is the posterior circulation, and that include the cerebellum here as well as the brainstem. So these are the areas supplied by the anterior middle cerebral arteries, and this is the area supplied by the posterior cerebral artery. So if you know the circulation of the brain and the area supplied by these cerebral arteries, then it will be easier for you to localize which artery is supplying that part of the brain is involved in any particular syndrome. The anterior circulation, which if is anterior circulation is both, and that's anterior cerebral artery as well as middle cerebral artery. So this could be the partial anterior stroke or partial anterior circulation syndrome, or the complete anterior cerebral stroke when both the arteries are involved. If either one, or the anterior or the middle cerebral arteries are involved, that is called the partial anterior circulation syndrome. So in anterior cerebral artery, the just anterior cerebral artery is involved, then the lesion, the neurological sign will be the contralateral leg, which is affected more than the arm. There's weakness. The weakness in the contralateral leg, and the contralateral monobrace, the foot of the leg, could be the presentation. Contralateral grasp, there's the frontal lobe sign, so will usually apparent. The contralateral grasp means that the grasp reflex is the reflex which is present in the infant people and infants less than 2 years of age. If you scratch the palm of the patient and the boy, the child, and they will just grasp the finger or that. And this is present only in the infant, but after 2 years, this grasp disappears. But if the frontal lobe lesion, if the frontal lobe is involved in any, either a circulatory defect or any other structural defect, so that the grasp reflex will reappear, and this will be present in the opposite arm. So weakness on the opposite side, the more marked in the leg than in the arm, or either contralateral monobrace, one arm or the leg is involved, and the contralateral grasp reflex is present. That means the frontal lobe is involved, and the anterior cerebral circulation is involved, the anterior cerebral artery is involved. Another sign which will be apparent with lack of spontaneity, which is called abulia. The patient can't start the thing on their own spontaneously. And this is the frontal lobe sign and anterior cerebral artery circulation sign. And this all involved continence, either urinary fecal continence, and because there will be no control from the involvement of the frontal lobe, and that is the result of a problem with anterior cerebral artery circulation. So the other part of the anterior circulation is the middle cerebral artery. So lesion of the middle cerebral artery, or the stroke or hemorrhage, and we'll discuss this thing at some other time, will result in contralateral hemiplegia. The whole side of the opposite body will be involved. There will be weakness. Arm and face weakness are more than the leg weakness in middle cerebral artery, and there will be contralateral hemianesthesia. The contralateral homonymous hemianosmia, the half of the visual field of the opposite side will be affected. And if the dominant lobe is involved, that is involved in the speech area, which is mostly in the left hemisphere in the right-handed people, and the right hemisphere in the left-handed person in most of the people. So that will affect aphasia, the defect in the speech, motor aphasia, or sensory, receptive aphasia. And if the non-dominant hemisphere is involved, they will neglect, the patient will be neglecting that part of the body, and gaze preferences toward the site of the lesion. The clinical classification of this circulatory defects is, as I mentioned earlier, that there will be total anterior circulation syndrome when both anterior and middle cerebral arteries are involved. The blockage in the common carotid artery, and that affects the circulation in the territories of anterior cerebral artery and middle cerebral arteries. So this will result, which is called as total anterior circulation syndrome. We'll discuss this sign apparent. When one of these arteries involved, either the anterior cerebral artery or the middle cerebral artery, then it's called the partial anterior circulation syndrome. The posterior circulation syndrome is with the vertebrovascular system, and the lacunar syndrome, in which one of the branches of the arteries is just involved, not the entire artery is involved. So one of the just small branch of any of the major arteries is involved, that will result in the lacunar syndrome. So total anterior circulation syndrome, where carotid are both main internal carotid arteries involved, affecting both circulation, both the territories of anterior cerebral circulation and middle cerebral artery circulation. Posterior circulation is when the vertebrovascular system is involved, and the lacunar syndrome when small branches of any of these major arteries is affected. So we need to consider three questions when localizing lesion to either of these arteries. Is there any visual field defect? So with the patient conscious, let's check for the visual field defects. Is there any heart function defect, dysphasia, or visual spatial inattention, or hemi-neglect? So let's let you know if two of these are involved, then probably anterior cerebral artery circulation. Are there any unilateral motor or sensory deficit? So if you review these three questions and you find, so all the three signs, that mean total anterior circulation artery syndrome. But if presence only one cortical sign indicates the partial anterior circulation syndrome, and absence of any cortical sign just indicates the lacunar syndrome, right? So total anterior circulation syndrome, where if you know, either the result of the internal carotid artery problem involving both the anterior and middle cerebral arteries, will result in unilateral motor deficit of the face, arm, and leg. That will be on the one side is involvement of the face, arm, and leg on opposite side of the syndrome. Homonymous hemianopia, that's one side, both hemisphere, visual field defects, visual field. So half of the visual field on the same side, homonymous. So that is the result of the total anterior circulation. Higher cerebral dysfunction, for example, dysphasia, or sensory inattention, and urinary incontinence, and these are the features of total anterior circulation syndrome. So the partial anterior circulation syndrome will result in, partial mean either internal and anterior cerebral artery or middle cerebral artery are involved, unilateral motor or sensory deficit, or both, and ipsilateral hemianopsia or higher cerebral dysfunction. Higher cerebral dysfunction alone or isolated motor or sensory deficit are both restricted to one part of the limb or the face. So it's not with the complete loss of motor function and the sensory function or the frontal lobe function, but the part of these areas will be involved, and this will result partial features on the opposite side of the body. Posterior artery circulation syndrome, so will result in one or more of the following: the bilateral motor or sensory sign not secondary to the brainstem compression by supraanterior lesion. So this is we can need to rule out the brainstem compression from the mass effect of the lesion, but it's there will be bilateral sign of the brainstem, cerebellar sign usually present unless accompanied by the ipsilateral motor deficit. unequivocal diplopia with or without external ocular muscle palsy. So double vision, the cross signs, for example, the left facial and the right limb weakness, the cranial nerve sign on the one side, the limb weakness on the other side. The cross signs are features of the posterior artery circulation the defect. Hemianopia alone or when any of the four items above. So these are the features of posterior artery circulation deficits. So I mentioned the posterior circulation is vertebrobasilar. The cross finding mean cranial nerve defect on one side and neurological deficit other left of the body part of the opposite side. So double vision, dizziness, ataxia, these are the cerebellar signs with vertebral system, contralateral hemianopia, color anomia, can't name colors when it affects the dominant hemisphere. There will be mild contralateral hemiparesis or mild contralateral hemianesthesia, but the maybe hemiparesis or hemianesthesia with on the opposite side. This is another syndrome which is called lateral medullary syndrome or Wallenberg syndrome, and this is the result of the vertebral basilar artery deficit, and this can result with the brainstem circulation affecting the cranial nerves 9, 10, which where the muscles, the palate, and the throat, and this will result in dysphagia and dysarthria. Dysphagia mean difficulty in swallowing, and dysarthria means difficulty in producing speech. So these are the brainstem signs. Ipsilateral Harner syndrome, that the sympathetic lesion causing the ptosis, meiosis, and anhidrosis. Ptosis means dropping of the eyelid. Meiosis constriction of the pupil, and anhidrosis, the loss of sweating on that side. Ipsilateral facial numbness, and that the result of the fifth cranial nerve problem. So on the same side, the sensory deficit, and ipsilateral ataxia if the inferior cerebellar pedagogy, the inferior cerebral artery is involved. So, but there will be contralateral decreased pain and temperature affecting the spinothalamic tract. So these are the features. These are the lateral medullary syndrome, the lateral part of the medulla, which is affected by the posterior inferior cerebral artery deficit. So coming back to our question, 60 years old man with diabetes, hypertension, hyperlipidemia, sudden onset of agitation. Examination shows left hemiplegia and hemianesthesia. Patient has right gaze preference. So where is the lesion? So the rule number one is that if the lesion is one side of the brain, you will get the signs on the opposite side of the body. So the left hemiplegia and left hemianesthesia have a problem with the lesion with the right hemisphere. The right hemisphere means right circulation. And in right gaze preference means in the stroke patient, usually the gaze is toward the side of the lesion. But in epilepsy or the seizure activity, the patient gaze preference to the opposite side of the lesion. So the lesion is on the right side, but which artery is affected? And this is the right MCA. So, okay, the right middle cerebral artery is affecting all these things with the right hemiplegia, the left hemiplegia and hemianesthesia, and the right gaze preference. The right MCA, right middle cerebral artery, is affected. So why not right anterior cerebral artery? Because there are no executive function, the higher mental function deficit in this period, except for a little bit of agitation. But the more prominent features are the hemiplegia and hemianesthesia. Okay, another question. 60-year-old man with diabetes, hypertension, hypercholesterolemia, the same the past medical history. Again, sudden onset of mild hemiparesis and hemianesthesia. So mild right hemiparesis, hemianesthesia. So examination shows right upper homonymous quadranotopia. So what is the lesion? Which artery is involved? So right-sided hemiparesis with lesion on the left side, and right upper homonymous hemiquadranopia, the temporal lobe. So the problem with the left middle cerebral artery involving the temporal lobe and the motor area. Question number 3. 33-year-old female developed weakness, both legs 2 days after delivering a baby. She also complains of headache, but has no vomiting or nausea. On examination, muscle power is 4/5 in both the legs. Tone is decreased in both the legs. Knee and ankle reflexes are depressed, and plantars are bilaterally downgoing. Ophthalmoscopy revealed blurring of the disc margin. Rest of the examination is unremarkable. What will you do next? CT head, EEG, MRI head, MRV, that is MRI is with venography of the brain, and the lumbar puncture. I have specific report of this question and the presentation to just let you know that it's not only the artery which is which are the concerned with the blood circulation. There are something which is called if there is blood going into the brain, there's something which needs to drain the brain blood from the brain as well, and there is a venous system in the brain which drains the blood from the brain. So we really need to remember this thing, that there is maybe it's not only the arteries which may be involved, it may be the venous circulation or venous drainage which is affected and can result in neurological problem and neurological. So what we'll do next? The CT head, EEG, MRI head, MRV, lumbar puncture. So it is MRV, and I'll just briefly go through the venous circulation. So some idea that so there are different veins which are draining blood from different parts of the brain. The important one is the superior sagittal sinus, which is on the top of the brain and just going through the just adjacent to the both center of the both hemispheres, and then is from the posterior the occipital sinus and sigmoid sinus, which is draining from the brainstem, and then there's all some veins along with the major arteries, like the middle cerebral vein and superior cerebral veins. So these are the veins which are draining blood from different parts of the brain, and if anything, any vein is affected, so that will affect the part of the brain being drained by these veins. So especially the postpartum thrombosis, superior sagittal sinus is not an uncommon scenario. So don't forget that it may not be only the arteries, but the defect may be with the veins as well. So inferior sagittal sinus, the superior sagittal sinus, and then straight sinus, and these are the veins which are draining different parts of the brain. So now coming to the blood supply of the spinal cord, that's I've included with this lecture because this is really important. So spinal cord is supplied by the two, one anterior spinal artery and two posterior spinal arteries. Both of these are the branches of the aorta. But remember, the easiest way to remember this circulation is that the anterior spinal artery supplies the anterior 2/3 of the spinal cord, and the posterior spinal artery supplies one side, or the one artery supplies one side, and the other artery from the other side and supplies the posterior 1/3 of the spinal cord. So if there is lesion of the anterior spinal artery, that will affect the 2/3 of the anterior spinal cord, and you can imagine what are the tracks in this area of the spinal cord and what could be the effect of occlusion of the anterior spinal artery. And the posterior spinal artery, because it's just supplying 1/3 and only one side, is not that associated with the fact that because in this part of the spinal cord, you get the fasciculus gunatus and fasciculus gracilis, and what you call that posterior columns, and the sensation will be the vibration sense or joint proprioception or two-point discrimination or light touch with either side, that's on the same side. But with the anterior 2/3 of the spinal cord, because it's supplied by the anterior spinal artery, this will result in the damage to corticospinal tracts, damage to the spinothalamic tract. The corticospinal tract will result in hemiplegia below the level of the lesion, and anterior and lateral spinothalamic tract will affect the sensory part. So this is the this is the anterior part and this is the posterior part. The anterior spinal artery is supplying 2/3 of the spinal cord, and the posterior spinal artery will be supplying just one part of the posterior 1/3 of the spinal cord. And you can imagine that reminding yourself of the part of the brain, part of the tracts which are located in this part of the spinal cord. So anterior spinal artery will result in paraplegia, so maybe the bilateral motor dysfunction, loss of spinothalamic sensation, loss of touch, temperature, and pain, and preservation of the perception of vibration, because this area is supplied by the posterior spinal artery. And the posterior spinal artery supplies will result in the unilateral dorsal column sensation and the loss of perception, loss of two-point discrimination, and loss of vibration sense. And ataxia, this all will result in ataxia and with a positive rhomboic sign. So hypotonia, diminished and absent deep tendon reflexes because of the effect to some of the corticospinal fibers, but mainly it's affecting the posterior 1/3 of the spinal cord on one side and will result in unilateral dorsal column signs, while the anterior spinal artery will result in bilateral sign, including both the motor as well as the sensory, but the sensory fiber will be confined to the pain and temperature and touch. And that was my last slide. So if you have any comment, you can write me on my email. And this is the YouTube link. You can find this lecture on the YouTube and sooner. So our next part will be the fourth part that will discuss the lesion in the peripheral nervous system. Thank you for the patient listening, and I hope this will be useful for you. Thank you so very much.